Chapter 22 discusses disorders of hemostasis. Hemostasis refers to the stoppage of blood flow. The normal process of hemostasis is regulated by a complex array of activators and inhibitors that work to maintain blood fluidity and prevent blood from leaving that vascular compartment. Hemostasis is normal when it seals a blood vessel to prevent blood loss and hemorrhage, and it is abnormal when it causes inappropriate blood clotting or when clotting is insufficient to stop the flow of blood from the vascular compartment. So disorders of hemostasis fall into two main categories: the inappropriate formation of clots within the vascular system, which we call thrombosis, or the failure of blood to clot in response to an appropriate stimulus, and we call that bleeding. So thrombosis is inappropriate formation of clots, and bleeding is the failure of blood to clot in response to a stimuli. So again, those are the two kind of main categories of disorders of hemostasis. So there are three stages of normal hemostasis. The first is vascular constriction, followed by formation of a platelet plug, and then blood coagulation. And we'll talk about all of these stages. So vascular constriction. So vascular constriction or vessel spasms, you can kind of see that here in the insert where that vessel kind of closes down, or the lumen itself of the blood vessel gets smaller in diameter. And vessel spasm constricts the vessel and reduces blood flow. It is a transient event, meaning it usually lasts maybe minutes to hours. And what initiates that vessel spasm is the endothelial injury. So injury to that endothelial lining itself. That injury causes local and humoral mechanisms to be released that cause that vessel to spasm. And it does that initially to reduce the amount of potential bleeding or hemorrhage that occurs in that really initial tissue damage stage. So seconds after vessel injury, something called von Willebrand's factor is released from the endothelium. So that is a chemical mediator, and you can see it kind of spelled out here. Von Willebrand factor is released from the endothelium, and it binds to receptors directly on the platelets, which are platelets are moving around in the vascular system all the time, right? So von Willebrand factor attaches itself to receptors on the platelets, and that causes those platelets to adhere to the exposed collagen fibers at that site of injury. So those activated platelets start to stick themselves right to these exposed collagen factors at the site of injury. As the platelets adhere to the collagen fibers on that damaged vessel wall, they become activated, and they release two more chemical mediators, ADP and TXA2. ADP and TXA2 start to attract additional platelets to the site, and that leads to something called platelet aggregation. And that's what's kind of happening here. So more and more platelets attracted to the site, they start to kind of, I guess I'll say, pile up at that site of injury. And that starts to form something called a platelet plug. The next step is blood coagulation. There are two main pathways of coagulation, the intrinsic pathway and the extrinsic pathway. There are many kind of steps and clotting factors involved in both the intrinsic and extrinsic pathway. So many that I wouldn't ask you to be able to kind of identify and memorize every single step in that process. Just know that there are many clotting factors involved, some of which encourage further clotting. There are also different clotting factors in that intrinsic pathway that prevent coagulation. So just many different kind of pieces sort of to those pathways and puzzles. But what I want you to know is that both of those pathways, intrinsic and extrinsic pathways, come together to produce a clotting factor called factor X. And you can see that kind of right here. Then we convert factor X to factor XA. And factor XA is involved in converting prothrombin to thrombin. And then thrombin goes ahead and converts fibrinogen to fibrin. And fibrin is what forms a more permanent clot at that site of injury. Okay. These are also kind of the primary areas that are targeted by by drugs used to manipulate clotting in general. So we have things that break down fibrin, we have things that target factor XA. So again, don't worry about memorizing every step in these other pathways. This is the piece that I would want you to be somewhat familiar with in that kind of blood coagulation piece. So some just general requirements for blood clotting process that go along with some of those stages we already talked about. First of all, we need the presence of platelets, and platelets are produced in the bone marrow. And we'll talk a little bit about what happens in folks that don't have sufficient amount of platelets. You also need the presence of that von Willebrand factor because it's essential to generate that platelet adhesion and then further platelet aggregation. And so again, von Willebrand factor is something that's generated by the vessel endothelium. There are some people with genetic-based disorders that do not produce von Willebrand syndrome, and they are highly susceptible to things like bleeding. So that is an essential component of blood clotting. And then we also need all of those clotting factors that go into, especially into that intrinsic pathway of coagulation. And most of those clotting factors are synthesized in the liver, and most of them require vitamin K for their synthesis. So again, most of the coagulation factors are proteins that are synthesized in the liver. So patients with things like liver failure tend to also have significant bleeding issues. And again, the clotting cascade is a really complex system that requires a lot of different factors for it to work correctly. It's a really stepwise process that results in the conversion of soluble plasma proteins, finally into fibrinogen and fibrin, like you saw in that last slide. Because most of the inactive procoagulation factors or coagulation proteins are present and circulating in the blood at all times, it is important to have that really multi-step process because it ensures that we don't experience just these massive episodes of intravascular clotting. Because those things, again, they're circulating, they're moving around in the bloodstream all the time. We need that multi-step process to prevent us from just having all, this constant widespread clotting. But what that also means is that abnormalities in the clotting process can occur when one or more of those factors are deficient or when conditions lead to inappropriate activation of any of those steps, meaning that there are a lot of different conditions, a lot of things that can also go wrong or prevent that coagulation cascade from happening as it normally should. So other pieces of the formation of clot, so clot retraction and dissolution. So clot retraction and dissolution are also significant processes within hemostasis. So retraction occurs within a few minutes after a clot is formed. So the actin and myosin inside of the platelets that are trapped in that clot begin to contract almost in a manner similar to the contraction that we see in muscles. And as a result of this, the fibrin strands of the clot itself are sort of pulled towards the platelets. And they work to squeeze serum plasma that doesn't contain fibrinogen out of the clot. And the clot itself starts to kind of shrink. So that's retraction. The process of dissolution or clot dissolution starts shortly after a clot is formed. And it begins with activation of plasminogen. That's an inactive precursor of the proteolytic enzyme plasmin. So when a clot is formed, large amounts of plasminogen are trapped within that clot itself. And there's slow release of a powerful activator called TPA from those injured tissues. and from the vascular endothelium. And that converts plasminogen to plasma, which starts to digest the fibrin strands, causing that clot to dissolve. That's also an important thing to understand from a drug standpoint. We can administer medications that mimic the action of TPA to also break down or dissolve clots. And we can use those medications when clots have formed in dangerous places, right? Like in the cerebral vasculature. So they can be used to reverse stroke symptoms. Okay. So hypercoagulability. So some patients become what we call hypercoagulable or more prone to clotting because of increased overall function of platelets. So some conditions that can increase platelet function include atherosclerosis, diabetes, smoking, high blood lipid levels or high cholesterol levels, or increased number of platelets in general. So increased platelet function. So hypercoagulability due to increased platelet function usually results in increased platelet adhesion and the formation of platelet clots, and this can disrupt blood flow. So these platelets are adhering and forming clots to blood vessels where they really don't belong. And if they start to build up in those blood vessels, they can start to um, narrow the lumen of the blood vessel itself and disrupt the normal flow through that vessel. So we'll talk about that more when we get to kind of some of the cardiac and neuro kind of peripheral vascular related stuff. Um, but that's what's happening with increased platelet function within the blood vessels. So again, the causes of increased platelet function here that lead to disturbance in flow and to disturbance in flow are usually caused by maybe endothelial damage. So damage to the endothelial lining itself causes platelets to adhere to it and form clots where they don't belong. And also increased sensitivity of platelets to different factors that cause that adhesion and aggregation. So these are what we often term atherosclerotic plaques. So atherosclerotic plaques are occurring inside of blood vessels and they disturb blood flow. They also cause that endothelial damage and promote that overall platelet adherence. So platelets start to adhere to the vessel wall. They release growth factors that cause proliferation of smooth muscle and contribute further to that atherosclerosis development. So again, things like smoking, elevated blood cholesterol levels, hemodynamic stress, so things like hypertension, diabetes, these are all things that can predispose a patient to that vessel damage that then in turn leads to platelet adherence and thrombosis within the vessels. Now we'll talk about this process a bit more when we get to our discussion of cardiovascular disease, but it really is a process of hypercoagulability caused by increased platelet adherence. Other forms of hypocoagulability, these are conditions that cause accelerated activity of the coagulation system or those intrinsic coagulation pathways. So an increase in procoagulation factors or a decrease in anticoagulation factors within that coagulation cascade. Many of these are inherited disorders and some of them are acquired disorders. Um, so some acquired disorders that can lead to coagulation are things like pregnancy or postpartum conditions, use of oral contraceptives, post-surgical states, immobility, congestive heart failure, or malignancies. People with malignancies or cancers develop um, uh, venous thrombosis far more often than those without malignancy. So again, these are people who you might see hypercoagulability states, overall meaning that they're much more prone to clot formation. So hypercoagulability increases the risk of clot or thrombus formation in either the arterial or venous circulation. So thrombi that happen in the arterial system are usually associated with conditions that produce that turbulent flow and platelet adherence. So the hypercoagulability states that are caused by increased platelet activation are usually those that happen in the arterial system. So arterial clots closely related to hypercoagulability caused by increased platelet adherence. And clots that form in the venous system are usually associated with conditions that cause stasis of blood flow with increased concentrations of all of those coagulation factors. So all of those hypercoagulable states that cause venous thrombosis are usually the ones associated with changes to that coagulation cascade, often precipitated by reduced blood flow or stasis of blood flow. And it's important to understand that arterial thrombi and venous thrombi happen by separate mechanisms because the treatments of each will be different because of that difference in cause, right? So with arterial thrombi, our focus of treatment is more related to reducing endothelial damage and also providing medications that would prevent platelet adherence and aggregation. So medications like clopidogrel or aspirin are more effective here because they work directly on platelets. If we have a patient developing venous thrombi, our treatments and things are more focused on maybe reducing stasis by encouraging early mobility or using compression stockings or devices on the legs to keep blood flow moving in the veins. And then our medications are more closely directed at factors within the coagulation system, like warfarin, which acts on vitamin K, or some of our newer drugs, which act on that factor X at the end of those clotting systems. So again, important to understand the difference in how clotting forms within arterial and venous systems because it really speaks to the difference in treatment that we use to either prevent or to reduce clots in those two systems. So moving from clotting to causes of bleeding. So bleeding can be caused by an overall decrease in the number of platelets that are in the circulation. So depletion of platelets depletion of platelets usually can be pretty severe before it starts to increase someone's tendency to bleed, especially any spontaneous bleeding. So you can lose a lot of platelets. You can have a really low platelet count before you're really at risk of too much bleeding. But we can also see increased bleeding when patients have impaired platelet function. So this bleeding resulting from platelet deficiencies commonly occurs in the small vessels, so vessels maybe of the skin, so really, really small diameter vessels. And it's characterized by something called petechiae and purpura, which are clinical manifestations we see at the level of the skin. I have a picture of that kind of coming up. Um, Other things that can cause platelet defects. So thrombocytopenia results from a decrease in platelet production at the bone marrow itself, or it can be caused by what we call sequestration of platelets. So the spleen is an organ that kind of collects and stores a lot of different blood products. And if there is something that is causing those blood products to remain sequestered or to kind of stay in the spleen, then we'll have a reduction in circulating blood products, and platelets would be one of them. So what causes sequestration in the spleen? Well, one common cause that we'll talk about when we get to liver function is if there's an increase in the pressure in what we call the portal circulation, it can cause blood to back up into the spleen. So that's one potential cause of what we call splenic sequestration of platelets. Another cause of thrombocytopenia are things that decrease platelet survival, so that kind of destroy or kill off our circulating platelets. All of those things can lead to thrombocytopenia. So there are different types of thrombocytopenia. There's drug-induced thrombocytopenia, idiopathic thrombocytopenia purpura, which is thrombocytopenia of kind of an unknown cause, and thrombotic thrombocytopenic purpura. Um, so heparin-induced thrombocytopenia is kind of a common type. Um, it's caused by the binding of antibodies to platelet factor 4, which produces these immune complexes that start to activate platelets and leading to kind of overall thrombosis. We'll talk about all of these different types of platelet defects a bit more closely when we're together in person so we can start to differentiate some of these different causes and mechanisms. So the manifestations of thrombocytopenia, well, one is bleeding. We see bleeding maybe in the mucous membranes, especially the nose, the mouth, the gastrointestinal tract, and maybe the uterine cavity. Again, it commonly occurs in small vessels. So we see things like petechiae, which are these pinpoint purplish red spots. These are seen almost exclusively in conditions of platelet deficiency. And we also can see purpura, which are purple areas that look like bruising on the skin. So these are some pictures of petechiae over here on the left side and purpura, these kind of large, kind of bruise-like lesions that we see on the skin. So those are the platelet issues. So now let's talk about some of the coagulation defects. So deficiencies can arise because of defective synthesis of coagulation factors. They can happen because of different inherited diseases that cause deficiencies in coagulation factors, or they can arise from the increased consumption of clotting factors. We'll talk about one condition called DIC very specifically here. So again, a lot of different hereditary disorders can cause this. I'm not going to go too deeply into any of them. I'll just kind of mention them. So things like hemophilia A and B, von Willebrand disease, which causes an absence of that von Willebrand factor, any genetic disruption of production of clotting factors. So there are, again, a whole host of diseases that can be implicated here. Vitamin K is an essential cofactor for the synthesis of the majority of our clotting factors. And remember that that synthesis of those proteins largely happens in the liver. Vitamin K is a fat-soluble vitamin that is synthesized by the bacteria in the intestines. So this is actually something, vitamin K is something that is absent in newborns because they have never had any feeding to their gastrointestinal tract, right? They're getting all of their nutrients from mom via the placenta. So there's no intestinal creation of vitamin K by bacteria. And so we give newborns injections of vitamin K right at birth so that they can start to create those clotting factors. It's not a super common occurrence, but without vitamin K, newborns can actually have spontaneous and severe hemorrhage. And so that's why we administer that vitamin K, so that they can again start producing coagulation factors. Vitamin K is also the target of the drug warfarin. And so vitamin K is a sort of antidote to the effects of warfarin. Patients with vitamin K deficiency, the liver produces inactive clotting factors that result in abnormal bleeding. So without vitamin K, we cannot clot normally, and patients are more prone to bleeding. So a little bit more about a condition called disseminated intravascular coagulation. So this is characterized by widespread coagulation followed by widespread bleeding in the vascular compartment. It's not a disease in and of itself, it's a complication of a variety of conditions. So some common clinical conditions that may cause DIC include obstetric disorders, so birth itself can cause DIC in the mother. That accounts for about 50% of the cases of DIC that we see. So one of the most common causes of DIC are obstetric conditions. So something we watch for closely in, laboring mothers. It can also be caused by massive trauma. It can be caused by shock or sepsis, and it sometimes is caused by malignant diseases or cancer. It is a massive activation of the coagulation sequence that leads to the formation of these little microthrombi throughout the body. And those microthrombi can start to cause vessel occlusion and ischemia and necrosis of the organs and tissues that those vessels feed. Um, and while all of that clotting is happening, that massive activation of coagulation factors, that clot formation is starting to consume all of the available coagulation proteins and platelets. And once all of those things are consumed, we start to see this severe and potentially massive hemorrhaging once those coagulation factors are used up. So coagulation and microemboli really are characteristic of DIC, but usually the most acute manifestations that we see in clients are related to the uncontrolled bleeding. So things like petechia and purpura formation, oozing from any puncture site or site of injury, and potentially severe hemorrhage. So we talked about one of the common conditions here, 50% of cases are seen in laboring women. So uncontrolled uh, um, birth-related hemorrhage is a sign of DIC in that population. But we also, in addition to hemorrhage, we see tissue hypoxia and organ damage from the necrosis related to those microemboli forming. So we see renal, circulatory, and respiratory failure often in DIC. So this is a very serious and very potentially fatal condition, again, because of the widespread uh, um, bleeding and damage to tissues and organs themselves. So management and treatment of disseminated intravascular coagulation, first off, we need to manage the primary disease. So whatever is causing the DIC, we need to manage that first. And then we can replace those clotting components that are kind of being chewed up by this massive amount of clot formation, and then prevent any further activation of clotting. So we need to stop the clotting cascade as well. So we can administer things, many blood products, things like fresh frozen plasma or platelets or something called cryoprecipitate. These are common things that we might infuse in a patient with DIC.